Dr. Fichera, welcome so much, Cutting Edge. We're here at ASCRS 2025, San Diego. And looking over your history, I mean, you've been in this field for decades. You're considered a master, we'll say, of colorectal surgery. And my understanding is here at this conference, you're discussing fistulas and Crohn's disease. Is that what we're
Yeah, that's correct. It is my field of expertise, is what I like to do. Crohn's specifically, in the field of inflammatory bowel disease, is what I like. And there is nothing, in my opinion, more complicated than fistulizing disease in Crohn's. So there is a lot to learn, there's a lot to share, there is a lot to work on still.
I think the rest of us surgeons are looking around going, so you've cured this, right? You finally fixed this problem and we're done. So please tell me that that's where we're at.
We are going in that direction, and we are not there yet. There were several sessions already at this meeting where we get excited about the 50-60% success rate, so we're not there yet. We're working both on the medical side and the surgical side to get to that point, but Crohn's is a complex disease. We don't know all the answers, we don't know all the triggers, we don't know the genetic component yet, so it's hard to find a cure for something you do not know exactly how it develops.
Yeah, my understanding, I mean, we're not even sure what's causing this specifically. How is it that we have a disease that we see so much in the modern world, and yet we don't even know what's behind it?
I think it's because it's a complex disease. We have been looking at one factor, is the microbiome, is the genetics. I think it's a combination of all these different factors. We see it now in countries where it was unheard of, right? In Africa and some part of Asia where there was no Crohn's disease, and now there is. What has changed? So it's a multifactorial disease, and that's why it's hard to pin it to a specific etiology.
And why is it that on the fistula side, what's specific about Crohn's fistulas that make them so much worse?
It's because they are driven by the inflammation in the lumen, both at the perianal area as well as the enterocutaneous fistula, where we will be discussing this tomorrow, in fact. It's driven by a underlying inflammation, underlying active disease in the lumen. So it's not just the fistula itself, like in garden variety fistulas. You need to address that, you need to address the sepsis, you need to address the source of the fistula, which is the flare of the disease.
So, as the expert in the field, you walk into a room, you see a patient, they've got, let's say, numerous fistulas, and you know it's Crohn's based. What is your algorithm? How do you start going about the process of taking care of this patient?
So, first of all, history, right? These patients are usually diagnosed at an early age. They undergo a variety of medical treatment. They undergo a variety of different surgeries. They undergo a variety of different opinions. They have different opinions for surgeons and gastroenterologists. So first of all, I try to understand their understanding of the disease. So my first question is, what do you understand of your situation right now? And I get a sense of how, number one, informed they are. And again, it's not their fault, it's we educate them. If we don't educate, they don't know. And then I try to guide them towards what the options are. There are so many options, and some are often not realistic, so you need to narrow the wide spectrum of options into 2 or 3. And lastly, set some expectations. Somebody comes with multiple enterocutaneous fistula, there is no one surgery that will fix them. It's a process, it's medical optimization, nutritional optimization, control of sepsis, and likely multiple surgical interventions. So set those expectations so that the patient and the family and the treating physicians are all on the same page.
And you're saying that, and that includes the gastroenterologist, the other medical, so who should be part of that team?
Right. So first and foremost, the gastroenterologist. Right? You need to have a group of people that you work very closely with. A group of people, they also know the gastroenterologists in the community. They may refer to you or to them, and so create that circle of treating physicians that are all on the same page. Depending on the situation, the ostomy nurses, the integral part, nutritionist, integral part, radiology, intervention radiology, those are all part of the team. The gastroenterologists and the surgeons are the ones that really sort of play quarterback in this situation.
And you keep mentioning medically optimizing them. When you say that, can you kind of walk through what is that?
So medical optimization has changed over the years. When I started in this business, the only therapy available were corticosteroids, and we knew that they were great at controlling the disease, but not as good for postoperative recovery, postoperative complication, but we had nothing else. So either you are flaring or you are on steroids. And now there are so many other options that have less potential long-term side effects or post-operative complications associated with them, that is a way to sort of optimize the the medication regimen they are on at the time of surgery. So that's what I mean. And to do that, you need a gastroenterologist that knows treatment of Crohn's disease inside out. It's not just the medication, it's also the nutritional status. These patients are unable to eat, they're unable to keep things down, they have all sorts of other associated problems. So it's a process to get them to the best possible condition, to do the right surgery on the right patient at the right time.
Is there a way to break down what these new drugs look like? So a general surgeon or somebody that's dealing with this may see it, infrequently in the population, but it seems like these new therapies are coming out almost, every few months.
Oh, yeah.
And so how can you either want to keep up with it, or at least give a framework as to what they divide into? Like, what are these treating, and what's the timeline we should be giving those versus surgery?
So that's really the something we deal with all the time, because unless you are a dedicated gastroenterologist and surgeon for that matter to the field of inflammatory bowel disease, in my opinion, is impossible to keep up with the new medications. That there are few general classes of medications, but they all have some special activity, special mechanism of action that make them more appropriate for the specific patient. So as I said earlier, we started from having only corticosteroids to going now to personalized treatment of Crohn's disease. And unless you dedicate your career pretty much to the field of inflammatory bowel disease, there is no way to keep up with that.
I'm finding that, I'm an acute care surgeon by training, and I still do some colorectal work, but I really try to get away from it because it's almost impossible to keep up. And out in the community, it's difficult as well, though, because there's not always somebody who's specialized in Crohn's.
Right.
Is it getting to the point now where if you have a Crohn's patient, you should really be sending them to somebody that's all they do?
It's a tough question to answer. The reason being, you look at the country, there are areas of the country where not only you don't have a specialist, oftentimes you don't have a surgeon, you don't have a hospital. Without getting into the specific of the different states, but there are rural areas where the expertise are what they are, and it's nobody's fault. It's as I said, it's a very niche type of surgery, and unless you have a big volume, also that's important. Unless you have a big volume, you cannot develop those expertise. So the simple answer is yes. Can technically a simple ileocolic resection be done by anybody? Yes, for sure. The key is to do it at the right time, on the right medical treatment, on the right patient. So that is the difficult part. And that, I think, requires coordination with the gastroenterologist. And nowadays with Zooms and telemedicine, there is a lot more than can be done. We do a lot of telemedicine and virtual consultation with, from New York, people in Jersey, people in Florida, people in Dallas. So it's not as it used to be, where you actually physically have to get in a car and drive. So the simple answer is yes. The Crohn's patient should be discussed, if nothing else, with a specialist.
Now, as a surgeon, so we're talking to the other acute care surgeons or people that take a mercy call or whatever. You have a patient that comes in, they're being treated outside facility at one of the major centers, and now they're in your ER, they're on one of these medications. Are there any things in particular you need to recognize about these medications if you're going to have to operate on them emergently? And is there still a role in any way to put for steroids or anything like that in this case?
That's a great question. And I just came from a session that discussed optimization of IBD patients in preparation for surgery. The simple answer is corticosteroids are not ideal for patients that have to undergo surgery. Now, the problem I have with that is that we group corticosteroids under a single umbrella. There is the patient that has been on 20 of prednisone for 3 weeks, and the patient that has been on 10 milligrams of prednisone for 5 years. So it's dose, duration, and the patient itself. So corticosteroids in general should be weaned if possible. The other side of the equation is that you wean them, and then they flare. So, to find the right time where you want to do surgery, where they're not flaring out of control just because you want to get them off the steroids. For the other biologics in general, they seem, and the evidence becomes more and more convincing as we know more, to be safe in preparation for surgery. So it's less of an issue to try to wean them off before surgery. What I typically do is if somebody is scheduled for an infusion the day before surgery, I would ask them to not take the infusion. It's money that is wasted. The biologic therapy is directed to the area of disease, and you're going to remove that. So to give a very expensive medication a few days before makes no sense. But that's just the only reason. And the steroids, I'm very careful about weaning them because I would rather do surgery on somebody that has disease somewhat controlled, but on steroids, not 60 milligrams, rather than having somebody flaring out of control.
And so you're telling me though, if you're on, let's say, biologic, and you happen to get it infused 3-4 days ago, but now you're in the ER and I got to take you to surgery,
Right.
This is not an overwhelming problem to have to operate on them if they've recently received one of these.
It is not anymore.
Are there any things we do need to recognize because they've recently received these in the post-operative period that we should be aware of that's a potential worsening, like higher risk of this complication or some other comorbidity?
No, not in the immediate post-op. I mean, you have to use your judgment and do a resection, anastomosis, diversion, not diversion. So that is an intraoperative clinical judgment that is based not just on the medication but on nutrition and how the surgery went and all of that. So, but specific to the biologic in the post-op period, there is not much you need to worry about, compared to patients that were not on biologics.
So it's not going to cause any catastrophic problems with anastomosis failures or anything
No,
like
not
that?
the biologics. Yeah, the steroids could, and that's why you need to use your judgment. Do I do an anastomosis? Do I do an anastomosis with diversion, or it's safe to just do an anastomosis? So.
If there were any things you would tell a Crohn's patient to do the lifestyle changes
Right.
that you need to make if you either developed it or if you're talking to a patient that has Crohn's, what would be the things you say, look, you really need to do these?
Smoke. That's an easy question. If they are smoking, they need to quit. And the data is very clear that patients that smoke are more likely to undergo surgery, they're more likely to recur, and they're more likely to recur multiple times. So that's very clear. It's the simple thing to do. And the other one is to be compliant with the medication. Oftentimes it's not their fault. Insurance becomes an issue sometimes, and life gets in the way, people get pregnant or move, whatever, but being compliant with the medication is key. If you smoke, you throw money out the window, you throw biologics out the window, you're gonna get in trouble no matter what.
So can they still get biologics if they're smokers, or is it a contraindication?
No, it's not a contraindication. It's a waste, if you ask me. I do know of some colleagues that gastroenterologists that would not necessarily, but refuse to see patients that smoke unless they quit. I think that's pushing it a little too far. But I mean, we need to be very forceful with IBD, with Crohn's patients about smoking cessation. And yes, if you come to the emergency room, you need surgery, the ship has sailed. That's why I think the ball is in the gastroenterologist corner. When they start the treatment, the first thing they need to ask is, do you smoke? And if you smoke, you have to quit. Otherwise, you are going to get in trouble.
If you don't mind, I want to pivot a little bit and kind of talk more about ASCRS itself.
Yeah.
Where do you see ASCRS fitting into the bigger picture of the other societies? Do you see that what's the biggest advantage to coming out of fellowship? Why should you be a member of this society?
So that's a great question, and I can give you my personal experience. When I graduated, I wanted to be part of a community, right? You all of a sudden for a year, you only spoke the colorectal language. You were not talking about hernias and gallbladder anymore, and nothing wrong with that. Just you have been speaking one language for a year. You want to be part of a community. And this is the society that represents that community. So for a trainee, I think I had no questions that I was going to be a member and get involved more and more. And then you get the opportunity for networking, right? You meet your former colleagues, you meet people that you have interviewed with, you have people that you have trained with moving forward. And so that's for a younger person. Why you stay in the society is is because the society really offers a lot of leadership opportunities and interaction now with other international societies, European, Asian. So it gives you an avenue to explore and get to know other reality, other societies in less developed countries. So to get that global sense of colorectal community that otherwise you can't get. And I am members of other societies. It's just that I feel that this is my home because of what I do, because what I train, because what I believe, and for IBD surgery, this is the place to be.
Now, do they have any relationships with the gastroenterology societies?
Direct, no. The ASCRS has some combined sessions at Digestive Disease Week, combined with the International Society of Surgery, International Society of Digestive Surgery. So within the larger, the largest gastroenterology meeting, there is a presence, but a direct interaction, not necessarily. And that's perhaps is something that should be further developed. Now, there are gastroenterologists on sessions. The session I just attended, there was one that I know personally. So there are gastroenterologists that are invited and provide important input, but perhaps that's something that should be developed a little more.
And when it comes to, you've been moving through these societies for years now, and you understand how they work, and the bureaucracy of medicine really relies on the interaction with societies and the AMA and all this kind of interaction.
Right.
What have you learned about maneuvering through a society? What are some of the tricks or the things that I need to be aware of, or surgeons should be aware of how you become most effective within a group or an organization?
Again, I'll give you my experience and my opinion. You get involved, you're given an opportunity, make the most out of that opportunity. If you are on a committee, participate in a committee. Don't just be member so that you can put it on your CV. And that will allow you to get up in the leadership of that committee and perhaps the leadership of the society. So it's if you're passionate, show it, get involved, and do the work. Very, very simple. Maybe too simple, but.
Oh no!
Yeah.
I think that's definitely true.
Yeah.
And if you look at the general population, like all this knowledge of Crohn's and everything else, what would you say to somebody in the general population to understand Crohn's disease a little better? So if you, what are symptoms they may have to look at if they start having something that they should be, reaching out to a specialist for, or if you have Crohn's, what is the thing that you've seen come about in the last year or two that they probably need to recognize that they may not realize yet?
So our knowledge of Crohn's disease and also colitis, for that matter, is growing, as you said, on a weekly basis pretty much. So what we used to tell them 20 years ago is a totally different story. There is more awareness. The other society like the Crohn's and Colitis Foundation have done a lot of work to increase awareness of the disease. The symptoms are, diarrhea, bloody diarrhea with ulcerative colitis, less bloody with Crohn's disease, weight loss for teenagers and children, the failure to thrive and things like that oftentimes are delayed. Oh, he's not eating, he's a picky eater, he's not gaining weight, he doesn't like this. So be aware of the symptoms that sometimes are subtle. You don't want to present with, you don't want these people to present with an abscess or a fistula. So stay ahead of the game, because the medications work significantly better if you start early. Once you have a stricture, once you have an abscess, that it's a guaranteed surgery pretty much. And there is nothing wrong with surgery. Surgery is one of the treatment of the disease, but if you can get ahead of the game and delay surgery or avoid surgery altogether, would be best. So for the patients to be aware of their symptoms, and you may have a picky eater type of kid, but don't assume that is the case if they're also having diarrhea, for example.
And from a surgery standpoint, what mistake do you see that other surgeons tend to make when dealing with Crohn's patients that would be easy fix that they can stop doing?
Yeah, so what I say every time I give a lecture on Crohn's disease is do not treat your Crohn's disease patients like the other colorectal patients. So the type of surgery you would do, the timing of the surgery you would do is completely different. An intra-abdominal abscess in diverticulitis is a totally different animal than an intra-abdominal abscess in Crohn's disease. An intracutaneous fistula in diverticulitis, for example, is a totally different animal than an intracutaneous fistula in Crohn's disease, because we have medication that can address the source of the problem. So it's do not treat your patients like Crohn's patients like any other. The surgery is different. You need to be more cautious and careful about making an anastomosis, diverting, or time of surgery than any other condition associated, even associated with intra-abdominal sepsis.
Well, that's amazing. So thank you so much. Pleasure having you here, especially here in San Diego. So
yes.
Beautiful. And thank you again for coming on the Cutting Edge.
It was a pleasure, my pleasure. Thank you very much.
Thank you.